Thank you very much for the nice introduction. And I do understand a bit of Spanish, but unfortunately I don't speak it. It's good to be amongst here some colleagues whom I will have been working with in Europe. And I thank you again for the invitation. As Professor Holzgreve did, I will go over some issues today and dream with you a little bit about how we can proceed further. A little bit about Belgium. This is the Western Hemisphere. Belgium is the most bright spot on the world. If you look from outer space, because we leave our lights during the night on, all the highways are so dense. There's 10 million people living on a very small spot, and that gives a lot of light. Belgium is known for this. This is Brussels, the Atomium. And this probably you know. This is a painter, René Magritte. And he has made a very famous painting. And unfortunately, our country at this stage is also a very strange country, because at this moment, we are younger than you. We were established in 1830 as a kind of buffer between Germany and France that did fight every 50 years their own wars. But our problem is that we are an artificial country. The south speaking French, the north speaking Dutch. The Dutch living here are Catholics, the Dutch living there are Protestants, so that's a remnant of Spain's history here in our country. But these two don't really speak to each other. We fortunately have one king, and but we have no government for more than a year now. And that was commented on when we broke the world record of functioning without government in Iraq. We are doing worse. And that has led to actions like this radio commentator did let grow his beard, and he will let it grow until the government is formed. This is a professor of obstetrics and gynecology at the university, and she actually initiated an action that not a single woman would allow sex anymore until we have a government. Well, that was not very welcomed by most men, and we don't know what happens in her case, but this is already more than 100 days that she has launched that action. You know Belgium from other things. We are producers of chocolate, and we are the producers of more than 1,000 beers in our country, so that's 3 for every day of the year. So, but that's enough now about Belgium. I will speak about fetal surgery, and this is extremely to the point, as your country offers surgery for spina bifida, and it will really open the door for fetal surgery, I think. As you know, in Philadelphia and San Francisco, they did this study, the MOMS trial, where open fetal surgery was done to repair spina bifida, and that was on very selected cases that were operated on between 19 and 26 weeks in only 2 centers. One was stopped because it did not follow the rules, for lesions that were above sacral 2 and under thoracic 11. And it was a randomized study, and it was calculated such that the shunt rate would be decreased by the operation. And that was confirmed. In the prenatal surgery group, the number of shunts dropped from nearly 100% to around 70%. The number of babies with hindbrain herniation decreased, and the trial lasted that long that it was possible to give long-term results or medium-term results in the initially recruited patients. So at 30 months, they could show that the fetal surgery group had a better outcome. This was a score that was a combined score for developmental problems that were both motoric as cognitive. And what they showed is that that was better in fetal surgery, and that actually the number of babies that was walking independently is 42%, which is double of what you have with open repair. Sorry for the mishap because they changed the resolution. So this is at the backside of some maternal problems, and we must keep that in mind. And in a country like here, where mothers usually have babies later on. This is important to discuss. There is the maternal risk of pulmonary edema, which is much lower than we thought, abruptio. There is prematurity in the index pregnancy. There is membrane disruption, and as a consequence, oligohydramnios. And also, the risk for the next pregnancy is important. There is a 10% risk that there will be uterine dehiscence at the hysterotomy. We don't know what the clinical relevance is of that, but it's certainly something to be concerned about. So that's something we have to keep in mind when we implement this surgery. So what will that change now to the fetal surgery agenda? How do we deal with that? How do we implement that in each country? I would still hope that we can move away from surgery at all, just like in the previous talk, going from invasive to non-invasive. We must look for alternatives, and we will be using cell-based therapies, gene therapies, as well as tissue engineering in the near future. And what I would come to at the very end of my talk is to come to a form of personalized fetal medicine, where the therapy is adapted to the individual case. I will expand on these ideas. Open fetal surgery is what you know, general anesthesia of the mother, hysterotomy, but we can control these hysterotomies. We're already at a stage that we know how to do that. Fetal anesthesia is something we need for all different fetal therapies. This is possible in most countries because most of you already do kind of open surgeries. We organize ourselves for exit procedures, operations on placental support, where we will be creating access to the fetus. But can we translate that for myelomeningocele, for instance, to keyhole surgery? Well, there has been attempts already. In 2000, Joe Brunner published 4 cases of fetoscopic myelomeningocele repair. They all ended up in absolute misery, and that was abandoned soon after. In Europe, there is an active program at the University of Gießen by Thomas Kohl, where they repair the defect, but the word repair is wrongly chosen. What they do is cover the defect and then delay the repair until after birth, which is something completely different than what was shown in this trial. And at this stage, there is no evidence whatsoever that this helps for this condition. Second, we don't know whether this is a watertight repair, but because it is done with sutures, and a number of complications have already been named about that. So, but I think we have to move to something else, and the idea will be in single port coverage with hydrogels, with some glues that can cover the lesion so that we can achieve the same result as with open surgery and delay the surgery until after birth, but that we have a watertight coverage. And this has already been shown to work by a tissue engineering technique in Philadelphia. Let's move to the next step. When we speak to patients or lay people about stem cell technology, they always ask, what does that mean? Well, basically, a stem cell is just like milk. From milk, you can make yogurt, ice cream, cheese, whatever. So that's the stem cell product. Stem cell is a cell where you can make any organ with. That's at least the theory. And that was shown, actually, that, and it has already been implemented clinically for very selective conditions, that in utero stem cell transplantations can work. But that only has been shown to work well for immune deficiency disorders. So apparently, there has to be an immune deficit before we can use stem cells in utero. And that shows that the fetus is not that immunologically naive that we think. We ourselves are mainly focusing on mesenchymal stem cells that we retrieve from the amniotic fluid at the time of diagnosis. There is no ethical dilemma. It's not like embryonic stem cells. So it's really possible to do this. Nobody will have. And have any objection, and it's probably a better alternative than gonna sample the placenta after birth or take cord blood before pregnancy, delivery. It is possible to isolate these cells and expand them, and we can use these cells. So at the time of amniocentesis, you get your sample, and we tissue engineer whatever we want to make, and then after birth, the baby can get its own stem cell-derived product back. Stem cells will be used for tissue engineering. We focus on diaphragmatic hernia for obvious reasons. But you can use these cells as well for a gene therapeutic approach. You can transduce the baby's cells with whatever gene construct that you think is important for this baby with a certain condition. And this has been shown in sheep, for instance, that stem cells were taken from lambs, were isolated, expanded, transduced, expanded again, and then re-injected, and they could show, the group in the University College in London could show that these cells persisted until long time after birth, so it really makes sense to do it. And we could target with such cells that are carrying the gene of interest, the brain, the eyes, liver, diaphragm, or you could even target the bone marrow, for hemophilia. So I think that is really something that will change in the next years, and there is already good experimental evidence, only look at this column here, that you can transduce all these organs from this time point of weeks, human weeks expanded from sheep weeks, using this approach, either injected into the amniotic cavity, in the fetal circulation, etc. So the proof of principle is really there already. And we are focusing mainly on the lung because that's the only organ we do research in. And we definitely want to go for the lung, and the model disease is cystic fibrosis. We would like to target the fetal lung because it is still in the immune naive period, where there are less borders between the air fraction, which in fetal life is the lung liquid. There are less borders towards the airway epithelium. We also have a very small organ. When the fetus is still in utero, the number of cells to be targeted is less. There are already still progenitor cells that you can target, and also the contact with the tissue is long because the baby is not breathing. There is no ciliated activity that washes out your gene construct. And in the case of cystic fibrosis, you can transduce the lungs before they get damaged by postnatal airway infection. And we have shown in rats already that these were control rats. These were rats that were injected into the lung, into the liver, or into the intraperitoneal cavity. And you can see here bioluminescence activity. This is transduction with green fluorescent protein or a firefly luciferase. And look here at, as the rat grows, it keeps on expressing at the age of 10 months, which is the equivalent of 70 years in a clinical person like you and me, that this rat lifelong will express the gene that you have induced, and that will make it possible to treat, for instance, lung disorders. And we have now shown that as well for mice, so we have downscaled the size and because it's a much easier animal to work with. Now to finish, something that is happening today, which I think will have only a temporary place in fetal medicine, that is fetal surgery for diaphragmatic hernia. In a summary, for those that will not be here with us later on, this is the survival rate based on the lung size, so percentage of the normal, in babies that have either the liver in or outside the abdomen, into the thorax. And you see here there is a direct relationship, there is a severity pattern here clearly there. And in the ones that will not survive, less than 20%, they are the target of current fetal surgery. And we are doing a trial to evaluate the value of that fetal surgery. What we basically do is intubate percutaneously a fetus with a fetoscope that is no different than the one that you use for transfusion syndrome. You actually deploy a balloon into the trachea under direct vision. You do that at 26 weeks, and you remove it at 34 weeks to enhance lung maturity. It's a procedure that is done under local anesthesia with fetal immobilization and fetal pain relief. Here are the vocal cords. We go down into the windpipe and gonna deliver there a balloon. The balloon occludes the trachea. The lungs produce fluid. This blows up the lung, and this is a signal for lung growth. This is the carina, and this is the balloon. The balloon makes the job, but is also the nuisance. Because if this woman now will deliver prematurely, and every fetal medicine specialist knows this can happen after an invasive procedure, you have a baby that will be born in the middle of the night with occluded airways, and that will die if you cannot get this balloon out immediately. So how do we do that? Ideally, we take it out at 34 weeks for a variety of reasons. We either puncture it. You can see here the needle coming down. We did so in our experience in more than 200 cases in 20% of the cases. In the majority, we actually use fetoscopy. It's easier and more doable, less dangerous because it's really difficult. You go through a number of structures here that you don't want to touch. And here you see the balloon being retrieved by fetoscopy. If the woman would deliver very early and you have no time to do that, in 2 out of 10, we will do this on placental support. And in a number of cases, we had to do it actually after birth, but that's certainly not recommendable. Here is a summary of results. In black, expectant management. In blue, the effect of fetal surgery. Apparently, there is an increase that is dependent on the lung size. So small lungs, small increase, bigger lungs, big increase. The survival rate is dependent on the gestational age at delivery and also whether you are able to remove the balloon before birth or not. So if a woman comes in early labor, we always try to get the balloon out before birth. More than a day before birth is recommendable. We also have now data that the morbidity is reduced, and I will go into that in one of the next lectures. To finish, I would like to expand now a little bit on what I mean with personalized medicine, and I will use the example of diaphragmatic hernia. What this shows is that 80% of the population is not surviving after fetal therapy. We would like to know ahead of time who that is. And that means that we will have to type our patient not only by morphology, lung size, vascular studies, but we would like to know what is this tissue? Will this be a tissue that we can expand? That means an improved diagnosis. And with diagnosis, I don't mean the absence of anomalies. We now have developed, some may have seen that in the literature, a very special array that can be used for diaphragmatic hernia that rules out a whole series of genes that we know that are involved with diaphragmatic hernia. We are now at the level that we are sequencing our patients in a hope to see a pattern in those that do not survive at the genetic level. So we have to go from phenotype to genotype. And what we really would like to know is to look at the gene expression after fetal therapy. Because if you analyze into the body fluids, the tracheal fluid, the amniotic fluid, the blood of the fetus, you could be able to analyze gene expression, and then you can see what corresponds with survivors and non-survivors. This may be information that you can use to target, to improve your therapy, or this can provide information that you can say before the operation, look here, despite with our current fetal therapy, this baby will not respond. We will not do the surgery, and we will leave it to nature. And that, I think, is a very personalized medicine. And this must be possible within 5 years because the data are underway, the samples are there, it's just a matter of understanding. And we do so in the following way. That's for researchers. We are now looking at animal models, and we are looking at the gene expression profiles of baby rats with diaphragmatic hernia undergoing tracheal occlusion, and we are now sampling, both in Barcelona, London, and Leuven, the fetuses that undergo therapy, and we correlate the response with the gene expression. We know there is a difference in pattern, because following fetal therapy, we can actually measure the lung response. And look here, this is a plot of survivors in blue before the balloon goes in, after 1 day, 4 weeks, 6 weeks, and when the balloon is removed, and we measure the lung volume, which is probably the best correlate of what happens after birth. And you see in survivors, they go from around 30% of the normal up to the normal range. Of course, if you remove the balloon, the lung implodes because all the fluid goes out, but look, it ends up 20% higher than at initial. And in the babies that do not die, that doesn't happen. They end up at the same. So these two patterns must correspond with something we can measure in that fetus, and that's how I think we will find it. So I think that was a little dream of what we could do in the next 5 to 10 years. I hope you are as puzzled by the problems as I am, and if there are any questions, I will be happy to take them. Thank you.